this is the retainer on the abutment tooth. These are the adjacent teeth, which is called abutment tooth. We have to prepare these teeth, and over it we have to make the crowns, which is called as a retainer. And between the pontic and the retainer, there is a connector there. What are the ideal requirements of the pontic? It should be smooth in all direction. Should be easily cleansable. There should be pinpoint pressure, and it should be free of the ridge. No irritation to the gingival tissues. It should facilitate the plaque control. Emergence profile should be good. There should be strength, longevity. It should be aesthetics. It will restore the function. There should be no abutment overloading, and the color should be stable. These are all the requirements. As you know, for anything which is into the patient's mouth, it should be color stable. And also with the long term, there's a food and there is pressure and all this. It have strength and stability, and it should be biocompatible and all these things. And pontic, what is the function of the pontic? As you all know, whatever you are going to replace, it has mastication, it has a speech, and it has the aesthetic purpose. Now, what do you mean by tissue contact? Tissue contact means the area of the contact with ridge, this much. And ideally, it should be small and it should be convex. There should be some oral hygiene consultation, that whatever the you are doing to replace it, that patient should be able to practice their oral hygiene. There should be no problem that they will not able to do the brushing or flossing or the super floss anything. They should use it easily to clean the prosthesis. Then that is very important thing, that is the residual ridge contour. You should know before, when you are going to make the this prosthesis, you should know what is the type of the residual ridge, because there are so many types of residual ridge that you should know. Why? Because if there's residual ridge resorption, what are the problem? There must be some food entrapment. Maybe if it is big, it will come to look like the black triangles there. Then there we have a classification of the residual ridge, and this is called as Siebert classification, and it has class N, which means this is a normal residual ridge in height and width. And then you have class 1, we can call it as a defect. And defect in class 1, if you see, you cannot see it here, it has deficiency in the width of the residual ridge. Class 2, if you see here, this is the this height is residual ridge height is reduced, and in class C this ridge height as well as width has been lost. So in these conditions, when you know what are your residual ridge conditions there, you should know how can you modify this residual ridge defects, because if you know how to correct this, then you are able to make the prosthesis nicely. Otherwise you are not able to make it nicely. There will be some defects here and the patient will not be satisfied. If you see that residual ridge height is not there, maybe you can make this root stained so that it will look like the exposed dentine. Or you can also add in this, you can stain here so that it will look like the root, or you can put some pink porcelain there or pink acrylic there so that it will stimulate the gingival tissue. Normally we prefer this porcelain because the porcelain is glazed and it has less chances of gathering the plaque. As you know, acrylic is naturally, it has some pore, so we prefer this pink porcelain there. Other than this, there's also one of the thing that is called as Andrews bridge. What we will do, if you see there's a long bridge area there and the height is less, so what we will do, you can see here are good results there. We have to place some of the metal bar, which is attached by the these are the fixed retainers on the abutment tooth. And on this bar we have to attach our pink not the pink, our artificial teeth, acrylic teeth in there. Okay, we will attach the acrylic teeth on this bar so that it will give you this area. It should be covered, as well as you will put some gingival pink porcelain there so that it will add to the width and height of this case, especially in class 2 or class 3. Now, normally, what is the problem that in the class 1 there is less surgical management, because we will do this class 1 with the modification of the Pontic. But for class 2 and class 3, because it is less in height, we have to do some surgical management. So, what is this? We can either we make it roll technique, or we can make it a pouch technique like this. What we will do, because we want only the width of the residual, so we will just give it an incision here. You see the incision here, and this tissue we will thin it out and roll it back into the pouch and stitch there. This is your roll technique. In the pouch technique, what you will do, you will make the incision there. This is also roll and pouch technique, both for the class 1. You will make the cuts here, expose that area, and then you have to put some subepithelial or submucosal graft that should be harvested from the palate or tuberosity. What you will do, you will remove the from the especially from the molar area, palate area, or tuberosity area. You will take the some this graft part, or you can call the subepithelial or submucosal graft. You will take from the same patient, and you will open this area, and you will put this graft, small graft, and you will stitch that up. This is your pouch technique. It will give you only the increase in the width. Now, for if you are doing some height, then this small area will not help you. So you have to put some interpositional grafts there. And what is this interpositional graft? It is a variation of the pouch technique actually, in which a wedge-shaped connective tissue graft is inserted into the pouch preparation on the facial aspect of the residual ridge. And this is, you see, this is the wedge shape, and this epithelial portion it should place on the coronal part, and you have to stitch it up. This only graft is designed to give the ridge height, but also contribute to the ridge width, which make it useful for treating class 3 ridge defect as well. It is actually the free gingival graft that is harvested from the partial or full thickness palatal donor sites. Because the amount of the height augmentation can be only as thick as the graph, the procedure may be repeated several times to restore the normal height. And what is this management, if you can call it? Uh, this is the onlay graft for the augmentation of the ridge width and height. What you have to do, you first, you can see this first, this is the prepared teeth here, prepared teeth are there. And then if you see, we are just giving it the anesthesia, and we are giving here a cuts. The most important thing in your this only graft is that if the vascularization is good, then only it will work. Otherwise, if the vascularization is not there and you have not prepared this bed, then you will not gain so much of the results you expected. Once you prepare this, you have to prepare you have to put here some onlay graph, and then you have to stitch it up in the place. Now this is all about your residual ridge. Now you have to talk about the pontic designs. Now we have different type of pontic design, and we are using it in the different situations. Now, depending on the shape of the surface, which contact the ridge, we have saddle or ridge lap, we have modified ridge lap, you have hygienic, or you can call it a sanitary or conical and ovate. First of all, we will discuss with the sanitary. This is called as sanitary type or the hygienic type of the Pontic. If you see why it is called as a sanitary or hygienic type of Pontic, because if you see here, this is short of the ridge area, and there's so much of the space there. Okay. So you can also divide it with the mucosal contact or no mucosal contact also, because some of the I will discuss this Pontic design like ridge lap, modified ridge lap, ovate, and conical. They have the mucosal contact with the ridge. But like sanitary, which I'm telling you now, or the modified sanitary, they don't have any contact with the ridge area. So if you see here, why we are giving this space, because it will permit easy plaque control. And how? Because we can easily put gauze strips or even any clinical devices so that it will pass under the pontic, and you will move it in seesaw or shoe shine manner so that it will be clean in this area and there is no contact with the air. But the disadvantage of this design is that it have the entrapment of the food particles which may lead to the tongue habits that annoy the patient. You know, some of the patient, the space is there and they start using their tongue to remove that whatever the particles, it is stuck there. So this will annoy the habit of the patients later on. And the hygienic pontic. Another disadvantage that is that it is not tooth-like pontic, and therefore it should be reserved for those patients which seldom show these teeth during the functions, like mandibular molars, because the mandibular molars are not visible during your function. This is your sanitary, or you can call it a hygienic type. After these disadvantages, then they have modified this design and they made this area a sanitary point. This modified with an archway. This lower gingival portion, it's shaped like an archway between the retainers. And what is the advantage of this? One of the thing is that it will increase this connector size here, and it is less susceptible to the tissue proliferation that can occur when the pontic is too close to the residual ridge, and it is easy to remove the anything which is stuck there. So these are two type which has no contact. Now the other four type which has a contact is, this is the ridge lap design. The ridge lap design, it has a concave, you see here, it has a concave fitting surfaces that overlaps the residual ridge from buccal side as well as from the lingual side, and it will simulate the contours and the emergence profile for the missing tooth on both sides of the residual ridge. Here, buccal and lingual, both sides it has covered it, and it will look like that it has the same shape as the natural tooth. However, what is the problem? It should be avoided because the concave gingival surface of the pontic is not accessible for cleaning with the dental floss, and it leads to the plaque accumulation, and it will annoy the patient, and it will give you more surface area, is it will give you the tissue inflammation as well. So although it is very good, but it has excessive contours, that excessive contact with the residual ridge. Then what they will do, they will modify this ridge lab pontic as well. How they modified? This is same, it covers the buccal surface, but lingually it is short of the contact. And what is the purpose for this? It combines the best feature of the hygienic and the saddle pontic design, combining aesthetics and easy cleaning. Now, if you see here, only the facial side has been there, and it will give you the emergence profile, but still it will remain clear of the ridge on the lingual side. So optimal plaque control is there. Gingival surface must have no depression or hollow so that it will not give you the any oral hygiene problem. And if you see here the point, this contact point, it will be like a letter T of the English. This is your modified ridge lab design. It can be known as ridge lab design, or you can call it as a saddle design as well. It is the most common pontic form that is used and that is visible during the function. We can use it in maxillary as well as mandibular anterior teeth and maxillary premolars and first molar as well, which is visible. So we can use this design. Then another design is your conical pontic. You can call it an H shape, or you can call it a bullet shape, or heart shape, or conical pontic. It is easy for the patient to keep it clean because it is as convex as possible with only one point of contact at the center of the ridge. This design is recommended because it has a very small contact area. So definitely it has to be recommended for the mandibular posteriority, where aesthetic appearance is of no or less concerns. And if you see facial and lingual contours, they are dependent on the width of the residual ridge. So because it has a very less contact, we will made it and we will put it, or you can call the indication is a knife edge residual ridge, which has the flat contours with a narrow ridge contact areas. This type of design may be unsuitable for broad residual ridge because the emergence profile associated with the small tissue contact may create the area of food entrapment. And in those cases where there's a broad contact areas or broad residual ridge, and you want these which is not visible as well, so you can use the sanitary or a hygienic type of pontics in those type of clinical conditions. Yes, then you have the ovate pontic. This is the most aesthetically appealing pontic design. It has a convex tissue surface which reside in the soft tissue depression or hollow in the residual ridge, which make it appear that a tooth is literally emerging from the gingiva. And if you see here, but it needs a very careful designing. Why? Because this is like it has to fit in this depression. So we maintain this depression. How can we maintain it? Either we have to put it at the time of extraction. We will have some planning that at the time of extraction we will fill this area with a temporary crown which has the ovate pontic, so that when during the healing it will maintain this depression or something. Okay, and if you see here, these are all the maintenance of this thing, then it will come like this. Or if the residual ridge is there and you are not the patient will not come at that time, then you have to plan some surgery to make this depression and all these things which will cost the patient than the normal um, other type of thing. So the primary advantage, it has pleasing appearance and its strength. And if we are using normally with the ridge augmentation, then its emergence profile is very natural. And you have the problem. What are the problem there? That if you cannot maintain the oral hygiene, there will be the tissue inflammation. And also there's the charges for surgical tissue management. So these are the two big things there, because we have to maintain the